All right, so today we're going to speak about the hemodialysis axis, a couple of scenarios. We only have 4 scenarios, will be quick and easy. Who's going to start?
أنا جاهز.
جاهز. خلي سؤال صار الآن ما بلشت. سؤال.
Okay.
Okay, سؤال. Go ahead.
60 years old woman who is right hand dominant is referred to the clinic by nephrology for long-term hemodialysis access creation. She has polycystic kidney disease, GFR of 15, currently on transplant list. The nephrologist suspects she may go to need dialysis within 3 to 6 months. She has had no previous surgeries and never smoked.
Okay, so it's just like normal person. He's going to be in dialysis in 3-6 months, and they want us to give him an access. So the question would be, what you do next? Most probably, let me see. So what do you do next? So they send you to the clinic. You see, imagine you're in the clinic. This is a scenario sent to you. What are you going to do in the clinic?
I will take more history regarding previous accesses since when she is dialyzing.
No, just a second. She's not dialyzed, remember. You see, you have to read the question carefully, Suha, the exam. Let's go back again to the question. You see, the first suspect, she may go on dialysis.
Media.
So it's not being dialysis, okay?
Yeah. So I will start taking history about comorbidities, DM hypertension, atherosclerosis, hyperlipidemia. I want to know any history of previous line, central line insertion, or
why is that an important?
Because of possibility of central stenosis.
Correct. This is very important to ask. Okay, what else?
I will ask about any visible vein.
Okay, not us. This is an exam. So now you move to the exam, right?
Yeah, I will ask just in the family history, any history of previous history of clotting disorder or connective tissue disease. I will examine generally vital sign, heart and lung. I will examine her pulses in the peripherals and see the neuromotor.
Okay. And in the exam, what also you to look for? What you mentioned, but you mentioned.
I will if there is any visible veins or varicosities suggesting central stenosis.
Or arm swelling.
Okay,
this
yes.
thing you're back in your mind. So the venous, you have to look for central stenosis. You have to look for, obvious vein, arm swelling, previous mastectomy. If she has a mastectomy before, is an important to know, because she has maybe infections, So any question? So when you think about it, you think, I want to check the arterial and venous to be sure are open. Arterial is easy to check the pulses. Venous is more complicated. So you have to look for, for the venous problems. Okay. So he did that. She has no significant past medical history except for polycystic kidney causing chronic disease. And she never had a central venous catheters or beyond dialysis. In exam, there's no significant jugular vein distension or permanent chest wall vein. That's good. The extremity don't have any significant swelling. There aren't any visible vein in the upper extremity. Good. And the bilateral brachial and radial pulses are palpable. The brachial blood pressure are symmetric. What other workup would you order? So what do you do next step? I think it looks normal.
I want to order for her ABI, duplex ultrasound, and venous ultrasound.
You see, now you get yourself to trouble, Suha. Why you mention ABI? Why you want to do an ABI?
To make sure that the patient arterial system is fine.
Okay, so now I'll ask you how you do an ABI in the upper extremity.
We'll measure the pulse or radial and ulnar compared to brachial.
Okay, so it's they will not call ABI.
Yes, digit DBI, digit brachial index.
Okay, I don't know. I never heard about it, so I don't know. Do you read about it or just you make it up?
No, I read about it.
Read about it. Okay.
Yeah.
But usually, I mean, it's like as any normal person, if he has a palpable pulse, is normal. Why need to whatever big
Okay.
EVI?
Just I will do arterial duplex with venous mapping.
All right. I mean, but in real life, this I'm saying, guys, you have to imagine you are in the real life. You know, when a patient come to me with a good brachial, good radial ulnar pulses, why should I do arterial duplex? You know, I just send him for venous mapping because my most important for me to see the vein. You know.
Okay.
I mean, it's no problem doing it as extra, but in real life, I will not do it. And you know that we never do that, you know, unless she has like weak pulses, I understand, you know, but patient has palpable, you know, upper extremities, good brachial, good radial ulnar pulse. I will not do it. I just go right away to vein mapping. This is what my concern, you know,
Okay.
and look for venous also stenosis because venous stenosis could be or occlusion could be, you know, without symptoms. So you have to look for that. You want to be sure no DVT, you know. So this is what we're looking for. So the main thing we're going to concentrate on the venous release system. This is what I will do. All right, so let's see what happened here. On the arterial duplex, there is no evidence. You see, they order it, but it doesn't mean it's correct. You see, I said before many times, guys, it doesn't mean the book said that, then you have to do it. I don't agree with that. I don't think you need the arterial duplex, you know. It's no reason, you know. Even the book said that. But anyway, so did arterial duplex, which I don't think is an important. The brachial artery is 4 millimeters. This is an important. See the size of the artery. Yes, you do that, but not EBI. Yeah, when you do the vein mapping, you look at the artery. Of course, you have to look at the artery and look at the size of the artery. It's very important, and see if any calcification. So you do that. So I may take my word back. It's not arterial duplex really, as arterial scanning, or you can call arterial duplex. But usually when you do a vein mapping, always the technician, they look when I ask for vein mapping for AV axis, they do the venous and arterial same times. So if they mean by arterial duplex here to measure the size of the artery and to be sure no calcification, then I agree with arterial duplex. It has to be done, you know. But just to look for hemodynamic significant stenosis or not, I don't think we need it. So you see what's the difference? So if you want to do arterial duplex and he asks you why you want to do it, even have the pulses, then you tell me, yes, I want to do it because I want to see the size of the artery. I want to be sure there's no calcifications because patients with diabetes, they have a calcified artery. Even if you have a good pulse, if it's calcified, I cannot use for dialysis, then I will accept that from you. You understand?
Yes.
Okay, so this is the way we argue about it. All right, so the duplex ultrasound, no significant stenosis. Brachial artery is 4 millimeter and the radial artery is 2 millimeter. The vein mapping showed small and sclerotic forearm vein. Our arm cephalic vein is 3 to 4 millimeter, basilic vein 2 to 3 millimeter. Based on the history and objective finding, what operation would you offer her?
She has good size cephalic and basilic vein, but I will use the cephalic because the basilic, it will need a stage surgery. So I will do left brachycephalic fistula.
Okay. But again, I prefer not to talk too much in the exam because you may say something wrong, what you explaining something, you know, it's not an important.
Okay.
As history, what you finding, what your operation will do, you say, I will do
Left.
brachiocephalic AV fistula. That's it, you know.
Okay.
If you ask you why don't do basilic, it's going to say it's 1 stage or 2 stage, you know. Because if you say that, you say, okay, what you can do, brachiobasilic AV fistula 1 stage, you see, then you get yourself to more questions, which you don't need it, you know. Try to concentrate on the question, answer the question exactly what he asking for. So you do brachiocephalic AV fistula, correct. All right, what your criteria for artery and vein sizing for arteriovenous fistula? This is an important question, I think.
Vein, for the cephalic vein, 3 millimeter, and the artery, 3 to 4 millimeter.
Artery, what about the forearm?
Radial and ulnar, 2 millimeter.
Artery or vein? Artery.
The vein,
huh?
the vein is 3 millimeter.
Okay,
I
so
need
the
3
vein in
millimeter
forearm and arm the same, 3 millimeter, correct?
Yes, yes.
But the artery in the radial ulnar 2 meters is acceptable. In the brachial should be at least 4 millimeters.
Yes.
Okay, This is acceptable criteria. She agreed to have left brachycephalic fistula. Describe the surgery. How you do a surgery?
I will do for her left brachycephalic and the regional block after mapping
Why
using
regional block? Why not local or?
because the regional block, it will help dilate the vein.
Okay. Does it affect your patency?
Better anastomosis and also affect, yes, the patency.
So if you do nerve block, you have better patency than without nerve block?
I'm not sure, but I think yes.
Okay, that's good. Say I'm not sure. It's not no problem. Say I'm not sure. Yes, but the immediate patency is better, not the long-term patency. Long-term patency doesn't affect it, but the immediate patency, they found it to be better if you do nerve block because the vein is dilated, so you have less chance of early failure. But the long-term patency doesn't make a difference. Okay, but the early, the early failure is less with the nerve block because the vein dilated. All right. So describe a surgery. So how your incision? Tell me how you do your incision, what you cut, what you find. Yeah.
I will use ultrasound to map the cephalic vein and the brachial artery. I will use incision above the antecubital fossa. I will dissect the subcutaneous fat, identify the brachial artery, and control it proximal and distal with protection of the median nerve. Then I will identify the cephalic vein, ligate any branches, ligate it distally, and inflate it with heparin saline to make sure about the thrill. I will insert a coronary dilator to destroy the valve. Then I will make it enough length to reach the artery. I will heparinize the patient with 80 to 100 per kg and wait for ACT more than 250. Then I will ligate the vein distally, spatulate the edge, and do my anastomosis with the brachial artery into side. I will not make the anastomosis not more than 5 millimeter. After I finish, I will make sure I will do flush before finishing my anastomosis, allow for back bleeding, and complete my anastomosis, check for thrill, control hemostasis, and then I close my wound.
All right, Suha. I mean, you mentioned everything's correct, but the problem's order is not, and then surgery order is very important, So even though you said the step, but they are mixed up. So this is not good in the exam. Like in this one, even though you said all step correct, but I may give you only 50 on this one. I tell you why. First, when you open, you said, I go to the brachial artery and dissect and I find the brachial artery. You should find the vein first because vein is more superficial. If you go right away to the artery, you can damage the vein without you knowing that. So for me, if you do that, this is risky because if you're going to go right away to find the artery and the vein is more superficial, by cutting all this fat to get to the fascia, you may damage the vein. So the first thing when we open, we look at the vein and we find the vein and we protect the vein.
Okay.
So it's important to see, as I'm saying, you have to imagine yourself in surgery. Don't try to memorize step. Don't try to, just imagine you are in surgery and you do it really in real life. How you do? You open the skin, you find the vein. And the second thing, most failure come from the vein. So you have to be sure the vein is good,
Yes.
Because maybe you find it small, maybe you find it sclerotic, for some reason you don't have to continue down to the. So the first thing, I find the vein, the cephalic vein, push it to the side. Then I have to, before the artery, you have a fascia, you have to mention to me the fascia. Because if you don't mention that, you open the fascia, I imagine you're going to be looking forward for the artery for like half an hour. Because if you don't open the fascia, you cannot find the artery. So you have to open the fascia, find the artery. I agree with the median vein, you have to protect it, And after that, that's it. Everything's simplified. As you said, you cut, you do end-to-side anastomosis. I don't know if you mentioned that or not. You have to be end-to-side anastomosis, give heparin. You mentioned you put dilator to destroy the valve. This is not correct also. You see? As I'm saying, guys, try not to volunteer informations, I mean, yes, you put a dilator and get out, because why is not destroying the valve, because this is the flow of the vein, you know, it's from distal to proximal. So when you do a fistula,
Okay.
the normal flow is the vein, so it's with a valve direction, so we don't have to do destroy the valve. So you see, you mentioned this word, they may catch it against you. So again, try to be specific to the point. Just say the minimum, go to the point. I do 1, 2, 3, 4. Diater is good. I want to dilate the vein, be sure it's enough, you know. And
Yes.
then end the vein, cut it, ligate it, emphasize anastomosis, give heparin. Of course, don't forget heparin, as you said, to flush it. Anastomosis, you said, not more than 5 millimeters. I mean, yes and no. You should, because every brachial artery is different. I would say maybe not more than 2/3 of the circumferential be like more accurate, because if you have a big artery different, you have a small artery, correct? So anastomosis has to be proportional to the size of the artery. And then I don't know if you mentioned that the suture, you have to mention suture, like use 6-0 prolene, running suture, and that's it. Then you close in layers, you know. All right, that's good. Let's go to the next. Now let's say there's a good thrill in the fistula and radial pulse, but after the block wear off, she cannot move her hand and she's excruciating pain. What you concerned about? What you do about it? This is a very common scenario, and it's an important part. Yeah. So what do you think is going on?
Most common patients have ischemic monomyelic neuropathy and need ligation of the fistula.
Okay. She's in recovery room. When you put her, tomorrow or next day?
Immediately, I will take her back to OR for ligation.
What do you tell the patient before they cut the OR? She's going to tell you why take the OR.
She has low perfusion and it's affecting the median nerve and need to be ligated to get, otherwise it will have permanent damage.
Okay. Why is not a Steele syndrome?
I will examine the pulse and the fistula.
No, they already did that because they already gave you. They tell me. They gave you. She has a good thrill and she has a radial pulse. This is your answer because she has a good radial pulse. Correct?
Okay.
So it's not a Steele because they told you in that question. Oh, I told you, the examiner told you she has a
good thrill.
thrills doesn't differentiate between both, but the most important, the radial pulse.
Pulse.
If you have a good radial pulse, warm hand, and severe pain, then it
Yes.
is ischemic monomyelic neuropathy. If there's no pulse, hand looks cold, then most of it is a Steele syndrome, you know.
Yes.
So you told the patient that she has to go immediately to ligate the fistula. The reason why we don't, okay. It's going to tell you, I'm going to improve. I mean, it's going to be fine after that.
Because it's immediate post-operative. So with ligation of the fistula, the function expected to be back to normal.
Yeah, unfortunately, it's not. I mean, it's not guaranteed. So you have to tell the patient ahead of time, because she gets to this point, she has a severe ischemia. When the nerve gets ischemic, you know, they don't recover quick like a tissues, like a Steele syndrome. So tell her this is the only, you know, solution we have, but it's no guaranteeing. 50% they may still have a pain and get the damage, but you can't do anything. This is the only option you can help her. But don't give him too much hope, because sometimes they don't, even if they get emergency, they don't reverse it. But you have to do it, you know, still you have to do it, okay?
Okay.
Yeah, as an emergency. All right, so let's go back and say she does well with the axis creation without issue. How would you follow up this patient when you get to see her again?
I will see the patient after 2 weeks to check the wound and the suture, and then after 1 month, I will give her OBD with the duplex ultrasound to see the fistula maturation.
Okay. So she has no pain in the hand. There is a nitrate in the fistula, bulbar radial pulse, duplex demonstrate a vein outflow of 5 millimeters, diameter 4 millimeters from the skin, no significant velocity increase, volume flow 500. How will you interpret this result? Oh, let me ask you a different question. He may ask you, said, I'm going to see after 1 month to assess maturation, right?
Yes.
So the question I'm going to ask you is that, what is maturation? What's criteria for maturation? What you're looking for?
If it's the fistula from the skin, it's for not more than 6 millimeter from the skin, and if the vein size it's 6 millimeter or more, and the flow through the fistula more than 600 ml per minute.
So this is your definition of maturation,
Yes, this is the criteria.
for maturation. Okay, that's good. I accept that. So what do you think in this patient? Is she mature or not yet?
Not yet.
Because of,
Maybe she has a side branch or a venous
what
outflow.
could be anything.
I would
So, let's see what
I
next.
would do duplex ultrasound, evaluate with ultrasound.
Based on this finding, what you recommend to this one to do a duplex? You already did the duplex ultrasound. He came with a duplex
This
ultrasound.
is yeah. I will do fistulogram
Okay,
with possible intervention.
with possible.
With possible intervention.
Okay, why you want to do that?
I will do fistulogram according to the finding if there is any stenosis or venous outflow stenosis.
Okay. I don't know why just give her more. What? Because you see, the ultrasound didn't tell me she has a high velocity, correct?
Yes.
So he didn't give me any criteria. Just tell me the vein is not ready yet.
Give him a more duration trial for maturation.
And this has been only 1 month, so still early. Usually we give them at least
So another month. I will give him
another
OBD.
month. Yeah. So yeah,
Okay.
let's give another month and let's see. Try to exercise her hand, and then maybe I give another 2 or 3 weeks and reassess her again. Because
Okay.
this ultrasound didn't tell me any. At least they didn't give me any criteria. Told me she has a stenosis, she has a big vein. I don't know. So I will not jump. I mean, she's still like 1 month, still early. Usually we wait like a vein. Sometimes we wait for 2 months. So I will wait. I give it a couple of weeks and then repeat the ultrasound, and then I'll see. Then I'll go from. Then I become more aggressive. So I wait at least 6 to 8 weeks before I become aggressive with the fistula. So she went to the clinic. So she came. They gave her same. So she came to the clinic that meet your criteria. Now she meet the criteria. So I told the patient. She's right.
She can use her access for dialysis, and she will follow up with the nephrology. And if there is any problem, I will see her at that time.
Okay, that's good. Let's change the scenario a bit and say she had adequate forearm artery and vein for radiocephalic artery fistula. So they went back to the beginning. She
Okay.
came back, so he did, I think, radiocephalic fistula. She came back and has duplicate demonstrate 4 millimeter venous outflow. No significant stenosis and flow volume 350. The take also noticed some large venous side branch in the forearm. How do you interpret this finding? What do you do about it?
This fistula is not maturing because of the large venous branch. I will tell her that we can do surgery for her to ligate this branch.
Any
And then
other options other than surgery?
Sorry, what?
Is there any other option rather than surgery to ligate the branch?
We can do embolization.
Yeah, do colon embolization. Some people do colon embolizations. But I mean, it's not, I mean, it's right. Your answer is correct. But if you ask you, is any other option? You say yes, they can do a colon embolization. Okay.
Okay.
And this one didn't tell me how far when she came back. The reason why I didn't give her more time for maturation because they said she come back. They didn't tell me like 1 month like the other time.
Yes.
That's why we become, aggressive. And they mentioned that she has a large venous side. So like they're pushing you to this side. So like, it's a big venous side. You need to ligate it. So I agree with that. On repeat duplex scan, the vein is still 4 millimeters. So you did that and still the volume flow are only slightly improved to 400 as technician focused on anastomosis that measure 2 millimeter with velocity 600. So what's going on now?
So now the patient is having anastomotic stenosis,
Correct.
only 2 millimeter. So
not because
so
2 millimeter, because of the velocity.
Velocity high.
Yes.
Okay. Usually in this area, the anastomotic site should be 3 to 4. or it's fine too?
I mean, the most important is the velocity, because I don't know whoever covered, because I mean, I don't know who did the anastomosis, maybe he did small, but the most important velocity. If it's small, you're going to see high velocity, you know, so it's simple like that. If it's big, you
Okay.
don't see big velocity. So this tells you that she has a stenosis there. So
Okay,
what is your plan?
we'll book the patient for a fistulogram with the angioplasty of the anastomosis side.
Okay. How would you address that? How do you fistulogram anastomosis?
We'll puncture the vein
How do you
distal
puncture the vein?
in away from the anastomosis in retrograde fashion. Then I will put upgrade insert
What kind of anesthesia?
under local anesthesia with the conscious sedation.
Okay, local anesthesia, don't need concentration. Local anesthesia will be enough.
Okay.
And you puncture where exactly the vein you puncture? Close to the
Retrograde. No, away, retrograde in the vein.
Okay. So away from the anastomosis, you have space to
Yes,
walk, right?
yes.
Okay. And then you put a sheet.
And then insert wire and balloon to the anastomosis side. Before that, I will do
Wire size?
venogram
What wire size?
14.
Correct. It's 14 wire. Let me ask you what type of wire. So you see, this is a question we get in the exam. I'm asking what type, because I want to know really you want to know how to do it. So I ask you what type of wire, what type of catheters, you know. And then if you do fistulogram, okay, how are you going to do fistulogram? You put your sheath and inject a dye, or what you do?
After I put my sheet, I will hypernize the patient. Then I will apply pressure on the artery and then inject the contrast.
Good. Pressure on the artery where? Right above the anastomosis.
Above, no, proximate at the artery before the anastomosis side to evaluate the anastomosis area.
You confuse me. So you put the sheath and you put the pressure on the vein above the anastomosis, you said?
Above the sheet. Yeah.
Above the sheath, correct. So above the sheath.
Yes.
So this way you can force the blood to go down. Correct?
Yes.
Okay. Is there any other way to do it? If you do that and still you don't see it, you don't see the anastomosis. What other options? You can put the catheters, right? You can advance the catheter all the way to the artery and then inject through the catheters, okay?
Okay.
Because the catheter will go through the artery, then it's like, you know, and some people, they go through the artery, but I don't recommend that. I agree to go through the vein. I like to go through the vein. But some people, they go through the breaker artery, but I think it's too much. So the best way to go, as you said, retrograde, go through the vein, compress the outflow after the sheath, and do an angiogram. If you cannot see it, then I put a catheter in the radial artery, do an angiogram, find the stenosis, and then you balloon it, okay? So what kind of balloon you use?
I will start with the size of 3 millimeter, then I will go up as needed.
So you did that and still have a stenosis. What do you use?
High pressure balloon.
Correct. Or what other options? Cutting balloon. Correct?
Okay. Yes.
So you can use high pressure balloon or cutting balloon. Okay.
Yes.
All right. So what if you balloon the anastomosis, the vein was now only 4 meters with resolution of the stenosis? So you solve the issue. So what do you do now?
I will finish my surgery, then I will close the puncture side, apply pressure, then I will evaluate the patient after 4 weeks with duplex ultrasound.
Okay, this makes sense. Still, fistula is not maturing. What do you do? So after 4 weeks, I'll give him another maybe 2-3 weeks, still is not maturing. What do we do?
For this, I don't know, for this axis, maybe we'll create another axis.
I mean, still don't abandon it. I mean, you can, I mean, I have no problem with that. You can say, okay, it's not maturing, but still have a time. I don't know how old is she, young or not. Maybe you can still have a time, you know. This is something I always do that when I see that, unless she has a strong, but they told me she has a strong pulse, but sometimes, you know, you have to look for something more proximal. Maybe she has subclavian stenosis, breaker artery stenosis. You can,
Okay.
but this should be unrevealed from your venous, from arterial ultrasound from the beginning. So you may say,
Yes.
I'll go and review the arterial duplex before, just be sure I'm not missing any proximal stenosis. You know, this will, I will wait for that. Some people, they mature the vein by putting a balloon, just dilate the vein, you know.
Okay.
But if you did everything, then you revise it. Yes, I agree with that. Okay, let's say what they did an echo. Okay, sometimes you can do an echo, just be sure it has enough ejection fraction, because if it has echo is like 20, ejection fraction 20, 30, this will never mature. The patient running
Yeah,
out
but
of time.
usually we are doing the echo pre-fistula creation.
We don't do it like routinely, really. And you can see that in our practice, we don't do echo routinely for every AV access. But if you get to this point, you're stuck, then you go to retrospect and say, okay, maybe I'm missing something. Maybe his echo ejection fraction is low, then I order it. But if you order for every patient, you may be over treating the patient, I think, you know, be too much echo, you're ordering too many echoes, you know. Okay, so what if the patient are running off time and she was going to need dialysis? All this pre-dialysis with the next one, what do you do? So you did everything, still not maturing, and now she's still, I mean, she's running off time. She needs like next month, she needs something quick. What do you do?
I will do for her a proximal AV fistula. If she has the time, I will do for her brachycephalic. Otherwise, I will do for her AV graft.
You see, you give me 3 options. And I said many times, guys, in the exam, 3 options not acceptable. You have to give me 1 option, because this is what you're going to tell the patient. This is a scenario. Why you give me many options? You know everything about the patient now. You know how she's doing. And I'm telling you now, is only have 1 month left.
I will give her AV graft.
You give her a graft, correct. You know, we give her a graft because this is a very quick, you know, even though I will not, you know, the problem, I don't know, guys, who examine you. So people different, examiner different opinion. But in general, we don't like to give a graft as prophylactic for dialysis. Like, let's say this patient has no vein, all vein are bad. Don't do forearm AV graft or brachioauxiliary graft as preparing for dialysis. You know why?
No.
Okay. Because you see, graft has a lot of problem, high chance of thrombosis. And this all pre-dialysis. They may not dialyze. They tell you 2-3 months, but sometimes go maybe 6 months. Maybe come sometimes go for a year. You know. And the second thing is that why we do access before dialysis? Why we do access for that before dialysis? To prevent central catheters, correct? This is why we do it. And we know the vein, it takes long time to mature. The reason why we do the vein at least 3 months before the expected dialysis. So when dialysis comes, the vein will be ready, correct? But when you come to the graft is different because you can use a flexion graft, you know, we can it next day. So we don't need to then I can put a graft and do dialysis next day. So I don't need a catheters. So why I should put a graft like 2 months with all problem come with the graft, and then which I can be done when the patient become on dialysis, and then, you know, and then I do dialysis right away, because the graft, I can put a type of a graft which is can be cannulated next day within 24 hours. You see? So this is the way we argue about it. The reason why many times I see patient comes for AV graft for pre-dialysis, which I don't like. I don't accept that. Some people, they do that, but I don't like it. And I don't know in the exam if your examiner will like it or not, but if you want to discuss it, you can tell him this situation, because he may give you a scenario says no vein. Then he wants you to put a graft, but I will argue, I said, I don't like to do a graft for this reason. I prefer to wait until, and then I do, you know, flexion. If he tell you, okay, we don't have flexion in the country, we don't have flexion in your hospital, then yes, I may do a graft for dialysis to prevent, you know, central venous catheters. But if I have a flaxine available in a hospital, I think I prefer not to do it. Okay.
Okay.
All right. I think this is scenarios done. I did very good, Suha.
Thank you.
All right. Let's go to the next one. Who's that? Hamad, you want to take it?
Sure, doctor.
Any question before we go? Any question about this scenario?
That's clear.
Okay.
Thank you so much.
Okay.
So 67 years old woman presented to the emergency department with a pressure dressing on her arm due to prolonged bleeding from her fistula after dialysis. When they removed the needle, she has never had this happen before, but she noticed the nurse has been reading high return pressure for the past few weeks. She had left upper extremity brachiocephalic fistula, and she had never had any intervention on it since its creation 5 years back.
Good. All right. So I think will be question what you're going to do next. What are you going to do next?
Yes. So I will go to examine the patient in the emergency room, making sure that she's not bleeding stable, and we'll take more history and examination.
Okay.
So
what you're looking
yes.
for in the examine the patient? What you're looking for?
In examination, I will look for central venous stenosis
Okay.
finding.
And how you can see it?
A prominent nerve vein over the chest and the arm swelling, pseudoaneurysm over the fistula, face swelling, eye buffness. All of this is the major changes, yeah, and hand swelling too.
All right. Then after that, you can examine the bleeding area, right?
Yes, and then I'll examine locally the fistula.
What in the look in the fistula? What you are looking for exactly? I mean, why you need
So
to
I will look for the yeah.
Why you need to expose the dressing?
I will check for the skin integrity, presence of pseudoaneurysm, pulsatile bleeding or no, and but mainly about.
Why is that to make a difference for you? If there's any skin integrity or not?
So if there is a pseudoaneurysm with the necrotic skin, I think I had to take the patient urgently to the OR to revise this area.
Well, let's say no pseudoaneurysm, but the skin is ulcerated. What do you do?
So again, the same. I will speak to the patient that this fistula might bleed again, and this is called her bleeding. It might cause significant bleeding in the future, and I need to treat this urgently.
So you admit the patient and
admit the patient. Yes, I'll book her for. I keep her in the OR. I'll book her for surgery the same day if there is a disease. If there is
not same
the
day.
skin is
She came 6 p.m. at night.
Okay, maybe next day in the morning.
Then at middle of the night, they call you. The patient already caught it, and she has massive bleeding. What do you do?
So I'll take her emergency to the. Yeah, أنا كنت ناوي عشان.
كمان ناوي كملها.
I'll take her immediately to the OR. Yes.
Muhammad, when he ulcerated skin, that's it. I think about aneurysm under it, what not aneurysm, whatever. Ulcerated skin and the bleeding, this is a bomb. It's waiting to rupture. You have high pressure.
I'll take her immediately.
Yeah, I will take her right away to the surgery. Whatever I want to do, but don't sleep, because we saw a couple of cases. I don't know if you were there, but a couple of cases.
I took them with you.
So if the skin is intact, then yes, no rush at all.
Yes.
Then we just wait, put your dressing back, and then you can either you see the clinic, you can follow up. I'm not worried about as far as the skin is intact. The moment you see skin lacerated, or like you see a scab or a clot, and you say, oh, it's no more bleeding. You just see a clot at the orifice of the volcano, then no, it has to be addressed right away. Don't send them home. All right. There's no ulceration, and the period has a needle hole bleedings that are now stopped. The fistula is pulsatile without thrill. There is a distal radial pulse. What you're concerned about?
The central venous stenosis.
Correct. Slash occlusion, because we don't know.
Slash occlusion, yeah.
Correct. What workup would you do?
So I prefer to start with fistulogram, possible angioplasty.
Okay. So I have no problem with that. Some people may say you do a duplex ultrasound.
Duplex, yeah.
But for me, I don't think it's as an important. I know what information we get extra with duplex ultrasound. Mechanically, it's very obvious, you know. She has a pulsatile flow.
Yes.
You have bleeding from the hole. I mean, I don't know. But that's what the book said. They said you have to do duplex ultrasound, but I don't think it's needed. I think you can go right away. All right, duplex
High
ultrasound.
velocity
High velocity in the outflow vein, normal velocity at the arterial anastomosis, and low flow volume throughout. What's your interpretation of this finding and how you manage these patients?
Yeah, so no, the same fistulogram and angioplasty. Okay.
Correct. And intervention.
Yes.
How you do your operation? Describe that.
I will prevent drape the patient. I will puncture the fistula distal to the anastomosis, changing my Benson wire to
How do you puncture the fistula? How do you puncture it?
Under ultrasound guidance, sorry.
Okay. If you don't have
Guidance
ultrasound,
puncture.
what do you do? You don't have ultrasound.
So I'll do it blind but careful. I will use the same puncture site of the dialysis. So the same pinhole technique.
I don't think so. It's a good idea to go through the pinhole because there is a bleeding. But how you can facilitate your puncture? You just close the outflow. So when you close the outflow, you have like a pulsatile artery now. It's very superficial, so it's very easy to cannulate.
Yes.
So either you put a tourniquet or you put your thumb and you close your outflow. The moment you close your outflow, the vein will dilate it and become like pulsatile. I mean, it already has a pulsatile flow. So it's very easy. The most important is that to hold it between two fingers because the vein can move very easy. So you hold between two fingers to stabilize it, and then with the other hand, you go directly to the vein. And always in the vein, try to use a micropuncture. Don't go with a big needle right away because they go to spasm very easy, you know. So always try with a micropuncture, and then you do there, and you put your sheath. Okay. So you put your sheath, then what next you do?
You heparinize the patient.
Correct.
And you do diagnostic venogram.
Okay.
From the fistula to the central venous. You identify the problem and using soft angled proglide wire and can be catheter. You try to navigate to the left atrium.
Okay, and then what you do?
Right atrium. Then after that, you start with ballooning. You balloon, yes, for the area of the stenosis and the occlusion, and you check after the angiogram. If there is significant recoiling, you will balloon again, and you'll try to solve this problem with balloon. But if there is no improvement at all, you might need to stent at this time.
But before you stent, what you do? You mentioned that before. You have to use something else, the cutting balloon, right, or high pressure.
Cutting balloon, yeah, sure.
So you try with a balloon. If it's still a residual stenosis, I try higher pressure balloon, or I try cutting balloon because this is a fibrosis, you know, different from the MRCS system. If you do all the things, still have stenosis, then I will stent. Yes, for sure. Okay. All right. Venous university alone work well for treating stenosis. What's your treatment algorithm when treating venous stenosis that are refractory? We just mentioned that. Okay. So we don't have to stop at that. What if the techniques still do not resolve the stenosis? Then what you do?
I mentioned the stenting. If you cannot stent,
If you cannot stent,
if I cannot cross, I mean, this is a problem.
Okay. So if you don't cross, what do you do?
If I cannot cross, I have till I get this fistula. There is people they tried to do a sharp dissection or sharp puncture. sharp
Don't get
bicycle,
too soft.
but I'm not do it. Yeah. I will get this before.
Can do that, you know.
Yeah.
But
And
before
go
that,
to the
you
other side.
mentioned to me, I would try to go from the lower part, right? You try to go from the femoral.
Okay.
You see? So I'm saying,
Yeah.
just think logic, Muhammad. You try from above, you cannot cross it. Then I'll try to go from the femoral vein, try to cross it. If you cannot, then yes. Then either you don't have to ligate it really, because you can see if the vein is very nice all the way up like to the arch, like cephalic arch, then you may just put small jump graft to the auxiliary vein is open. You can put small jump graft and you solve his issue, you know. So it depends how is that. You can, so you can say, you see, if I have a surgical, then be a surgeon. If I have a surgical options for this fistula to save it, then I will go with that. If there's no surgical options, then I just ligate it. And then I'll do another, you know, like whatever other procedure. But if there's any easy surgical options, because sometimes I said, like usually what happens, the distal cephalic vein is occluded exactly when you go through the arch. This is the most common problems happens. So if you cannot cross it, you can dilate it. You just do a small jump graft from the distal cephalic vein to the auxiliary vein as an outflow. But if your main issue in the subclavian vein, then it's not going to work. So it's again, in the exam, you can argue with them, give them multiple scenario and how you deal with that. If they ask you, you know. All right, so let's take a step back and see the fistula does have a large bleeding ulceration. How do you manage this patient?
Yeah. A bleeding ulceration, I will take him immediately. I will debride the skin over that area, and I will resect.
So you can go ahead.
دكتور في المطار can someone take this scenario and I'll be back in
No
بس
problem.
after
Go
ما
ahead.
أسوي chicken.
All right, go ahead, no problems. Bassam here. Bassam, continue, Bassam.
أهلين يعطيك العافية دكتور. Let's take a step back and say the fistula does have a large bleeding ulceration. How would you manage this differently? Okay, if there is large ulceration, then we have to take the patient urgently to OR.
Correct.
To resect the ulcerated area and proceed. Maybe, yeah, I will do like primary repair or aneurysmography and close the wound, or also we can put interposition graft to bypass this diseased area.
Okay, is unacceptable, you know. And how you do your graft? If you want to put a graft, how you do your
venous to venous. We'll take, we'll just resect the diseased area and go proximal and distal to it, and do venous to venous to the graft and venous to the graft.
Okay. The only problem is that you see you already resect part of the skin, so the skin is already tight here.
Yeah, we tunnel it lateral to the wound.
So you don't leave the graft in the field of where you already resect the vein.
Yeah.
This is very easy. The wound will dehiscence and get exposed graft, then into other problem. So as you said, you go laterals, you tunnel it, you put under the skin away from the area, and then you do, as you said, anastomosis vein to graft and graft to vein. I agree with that. But the most important, to tunnel it laterally.
Okay.
All right, so patient goes on to have a successful dialysis through a revised axis graft. It's exactly what you did, and has a tunnel line removed. Okay. She presented to the clinic from dialysis unit 6 months later with return of clot and suspected graft thrombosis. What would you like to do? So she came with a thrombosed graft.
Yeah. I will do open thrombectomy of the graft.
Okay.
Fistulogram to assess for proximal stenosis or obstruction again, and deal with it. If there is stenosis or obstruction, we'll do again venoplasty.
Okay. Yes, clot with return of clot and suspected graft thrombosis. Okay, you can do that. I have no problem. But the most important, if you do thrombectomy, you have to do an angiogram because you have to find what's the problem. Thrombectomy alone is not enough because you thrombus. So you have to do a fistogram to look at the arterial or venous and fix it.
Okay.
Okay. I have no problem with that, but you can also say I'll do thrombolysis, right? You can do, but
Thrombolysis,
you
yeah.
don't do them. You don't do them. So I'll send to intervention radiology for thrombolysis was an intervention, but if it's not available, open thrombectomy is a good option, which is acceptable answer.
Okay.
All right, the last successful dialysis session was 3 days prior. The graph is pulsatile without a thrill. There's a distal radial pulse with normal neuromotor exam in the hand. What do you think is going on and how would you treat it?
I think thrombosis again. Since we have distal pulse, then it's only venous outflow problem. I think the fistula is thrombosed.
So what are you going to do?
For the last time, I will do either percutaneous thrombolysis by IR or open thrombectomy, and again venogram and venoplasty.
Okay, if needed. Okay. There is no sign of hyperkalemia on the lab. Of course, you see all the things. They want you also to order some lab because he didn't have the acid for a while. So
Yeah,
you want to be sure his no potassium is okay, so you don't have to put temporary catheters, you know. Or EKG and arteriovenous graft thrombose to break what you plan. You said that. Describe your plan. So how you do it? We already went through that, you know.
Yeah.
Yeah, do open thrombectomy. How you do that? It's an important question.
Open thrombectomy. I will open at the venous anastomosis, يعني proximal to the artery. Dissect, do control
Your
proximal.
incision will be close to the arterial or venous anastomosis?
Close to the arterial anastomosis.
Correct. Because most clot, the difficult one, close to the artery.
Yeah.
So try to keep as close as to the arterial. The venous is easy to come. The tough one is the arterial, you know?
Yeah.
So always try to be as close as to the arterial anastomosis, correct.
Yeah.
And then you make a small cut, okay?
And we'll pass the we'll give heparin, we'll pass the Fogarty and retrieve the clot, make sure good inflow and backflow, then I will close it. I will do also venogram, I will insert sheath and do venogram at the same session.
Okay. Anytime, always we call it fistogram, Sam. When you talk fistula, always call fistogram, don't go venogram, because venogram you went to the vein, fistogram mean the fistula. So always try to use the term fistogram. All right, so this is a high-grade cephalic vein, cephalic arch venous stenosis. What do you do?
We'll do balloon venoplasty. We use high pressure balloon and repeat the the fistulogram to assess if it is patent or not.
So you did that. So you did that, and there is a resolution of the venous stenosis with return of palpable thrill. What do you do next? Call for the day, right?
Yeah, it's fine. We just follow the patient up.
Yeah, just follow the patients. You know, you see in here we don't give aspirin and Plavix and all the things. Remember, this is a fistula, so we don't do that.
Yeah.
So we just follow up. Even after balloon angioplasty, we don't give antiplatelets in the venous. Okay. If you want to keep something, then it will be a DUAC, you know, or because venous antiplatelets, they don't work very well. Let's say this patient goes on to have successful dialysis for 3 months, return to clinic for prolonged bleeding. Again, access duplex demonstrate recurrent high-grade cephalic arch stenosis. So it came back. You look back in the chart and read that the same stenosis as being balloon angioplasty multiple times with multiple technique. Would you continue to treat this lesion endovascular?
Yeah. This area, we don't put stent. So I will go for surgical repair. Yeah.
And how would you do that?
We'll open over the area after identification of the stenotic area. We open small incision, identify the area, and either to do patch or interposition graft.
Okay. All right. I have some problem with that because to get to the cephalic arch stenosis is really hard. because this is where the vein, you know, dive deep between the muscle to go down to subclavian. So
Yeah.
to go to this area and do patch, I mean, at least I never saw it, you know.
Yeah.
I never saw this one being done, you know.
So the other
cannot
option is to
stent
like
it.
it.
I don't know why you cannot stent it. I have no
Can
problem
use
why you
mm,
stent the cephalic arch.
because it's over the shoulder. We can use
Shoulder,
like
really, no, if you think about cephalic arch,
Era.
it goes deep subclavicular in this area where it dive deep and go to subclavian, you know.
Mm.
So
So we can put
yeah, it's okay to stent in
this
the cephalic arch.
Mhm.
I don't know. I may try it. If it doesn't work, you can do a bypass. I will do a bypass if something like that. And if you don't want to stent, I think the easiest way is just to do a bypass, as you said, from the cephalic vein to the auxiliary vein. Small
Okay.
jump graft. I think it's the best way. Then grow, then to go there and digging down to get, because you have to get to the really, because it's also usually at the junction of cephalic vein with subclavian vein.
Yeah.
So imagine how difficult this area to get there and do a patch. You have to go down to subclavian vein, put a clamp, you know, I mean, and control it, and then do a patch angioplasty. And already this area ballooned many times, so be a lot of scar tissue. I don't think it's a good options, you know. Even if the book said that, I will not do that.
So we'll go
Because
bypass.
I'm saying in the exam, like here, even this is a book. If the examiner he want this one, I will not do it because I never did it. So I'll tell him I never did it. I don't know how to do it. I will just do a jump graft, and that's very simpler. Just small auxiliary incision and do small graft from the end of the cephalic vein before stenosis to the auxiliary vein.
The auxiliary vein.
10 minutes, I'm done. Why I should go
Okay.
on something I never did or never saw it?
Yeah.
So I'm saying, so if you don't know it, I prefer not to say, because if you say, they can tell you, okay, explain to me how you do a patch angioplasty for cephalic arch stenosis, you know, and you stop, you see. This is why I always say, and don't listen to the book. Don't listen to the people say. You do what you think you're going to do in real life, because this is what you're going to do in tomorrow after graduation when you get patient like that. What are you going to do? You're going to do just a bypass, short bypass, you know. Or even you can tell me, I may just like it and give a break auxiliary AV graft. I have no issue with that. As far as I know, you're doing something you know. But the worst thing to tell me something you don't know how to do it, you know. Then I imagine you're going to go there, dig there. You're looking for cephalic vein. You're looking for subclavian vein, and then you make it to bleeding, and it's a very narrow area. Then I feel you're not secure. This is a problem for me, you know. Then it'd be a problem for me. See, this is the way how through the process. Okay. All right. So what are some possible options for open surgical extraction of cephalic vein? We just talked about it. All right. So we're done. Good.
I have a question.
Go ahead, Suha.
What is our window in using thrombolysis in AV graft thrombosis, and is it different from autogenous than graft?
Very good questions. Autogenous usually you mean like a vein graft. Vein graft, they don't do well with thrombolysis because it happens, especially being for a long time. If it's thrombosed recently, it's okay. But it's been there like at least 4 weeks or more. Then the vein becomes fibrotic already. You cannot do thrombectomy. So you have to forget about it. The graft, no, the graft is different. Even 4 or 5 weeks, you can still do it because they don't do only thrombolysis, they do mechanical thrombectomy. And if you see them, they get a Foley and they push all the clot to the lung. I don't know how they do that, but the way they do it. If you look at interventional radiology or interventional nephrology, how they do thrombectomy, it's really scary. They just put in Fogarty and they push everything to the lung, you know? And they said nothing happened, but I don't know. So again, is a graft, I will be aggressive, more thrombolyzed open thrombectomy. When the vein thrombosed, usually is not a good sign. Unless thrombosed like recently, like within a couple of days, maybe a week maximum, you can do thrombectomy. But after that, you cannot do thrombectomy for fistula, for vein fistula, because they become fibrotic, you know. Okay.
Okay, clear. Thank you. Yes.
Yeah. Or any other questions? All right. Well, let's go. Me and Rafat. You want to take case number 3, Rafat?
Yes, please.
Okay, go ahead.
55 years old man who is right hand dominant present to the clinic with the continuous left hand pain at the wrist, and the symptoms have been progressively getting worse since he got the left upper extremity brachiocephalic AV fistula placed 4 weeks ago.
What do you think is going on?
Uh, possible Steele syndrome.
Steele syndrome, yes. It's a Steele syndrome, most probably, you know. So I
Yeah.
think this is a very common scenario. I think I'm afraid you can get these questions because they love Steele syndrome in the exam, you know, more than the ischemic neuropathy, because ischemic neuropathy, you cannot do much really, you just ligate it. But still, you have many options, so it's a big way for a lot of discussion, you know. So try to concentrate on this scenario and try to read about Steele, different surgery, how you do them, what the indication for different surgery. I'll read good about different type of surgery for Steele syndrome, what's the indication. We're going to go through them now, but this is an important scenario. All right, so what do you do next?
Started by the history and examination of the patient.
Okay. So
From the
what
history,
are you looking for?
from the history, the timing of the pain or the pain at the wrist or the dialysis, if there is any wound, ulcers, if there is history of the trauma, if there is any history of atherosclerosis risk factor, diabetic, hypertensive, smoking.
Okay, let's go to the exam. What do you do in the exam?
Examination, I will check the vital signs, then check the about the fistula, if there is any thrill, palpable distal pulse, if there is any ulcer, cyanosis, edema.
Okay. You think about what back in your mind? You think about what? You just told me. What back in your mind this patient has?
This is type 3.
Then I didn't ask about the type.
Uh,
I'm asking what do you think this patient has? He has a Steele syndrome, correct?
yeah, yes.
Okay. So when you have, like, when I see the patient, I think has a Steele syndrome. There are more on my question, my brain, and question and exam to rule it out or rule it in, right? So when I examine him, I want to see if he has a Steele or not. So what would you usually do?
Duplex
Exam.
ultras, compress the fistula and check the pulse.
Correct. So this is what you do. So you should tell me when I examine the patient, because I think he has a Steele syndrome, I'll compress the fistula and check the pulses, see if any change in the pulse, you know, feeling. So this will give you a hint that he may have a Steele syndrome. It doesn't rule it out completely or in, but to give you an idea, yes, we are dealing with Steele syndrome. The second thing is very important for me to know is his neurological problem. Is it reversible or not? Does he already has a fixed deformity in his finger or not? So I have to examine it. Because then what happened later, I can tell, oh, you already have it. I don't want him come after surgery and say, oh, doctor, this is what it caused to me. No, I have to document from he came to me, he already have a decreased sensation, he already have like, because this is legal issues, you know, and they may take you to the court because you damage his hand. But if you document when he came to you, he already has a deficiency, neurological or motors, then you're already protected. You can say, okay, honors, you know, this is what happens. He already came to me with this one. If you never mention it, it's a problem. So it's very important in your exam to give him a detailed, to write details, neurological exam. Okay, how the sensation, how the muscles, because patient is very easy for him to deny anything. Tell you, oh, when I came to you, it was fine. No, when you came to me, there was no sensation in the hand. You already have a deformity, you already have a cloud fingers, you know, so you document that, okay? So this is the most important when you come to the clinic and examine the patients. All right, let's do. There is no relevant history to report. There is a strong strain in the fistula, absent radial pulse as compared to the other hand. With compression of the outflow, the radial pulse become palpable. Good. See how they mentioned that the motor sensation of the hand is normal. So it's very important to look at that. This is the most two things I wanted to mention: the motor and sensation, and compression the graft in your exam. With delayed capillary refill, with no evidence of wound. Also, the wound is very important because your approach is different. Like you treat Steele syndrome like a wrist pain in the legs. You know, when you have a wrist pain, it's different than tissue loss. Wrist pain, you just need to increase flow maybe 20–30%. When we are dealing with tissue loss, then you have to increase blood flow more. And the same here with the hand. If you have a Steele syndrome with just pain and no ulcer, treatment will be different than Steele syndrome where we already have a wound or necrotic fingers, you know. So it's very, very important when you examine him to see if he has a necrotic wound or he has a necrotic fingers. So what additional testing would you do or you want to perform?
Duplex ultrasound
Okay, that's important to look at duplex ultrasound. You're looking
for
at you're looking at the duplex ultrasound.
the fl- to see the flow, volume of the flow and the repairs of the flow,
Okay,
and to assess the also the artery and the venous.
okay. If you send him like that, he will send you a report. Fistula is working very good. It's good flow through the fistula. So how's it going to help you this one? Did he answer your question if you have a Steele or not? No.
No.
So the reason why when you send him for the test, you have to send him, specify for him, I want you to do duplex ultrasound with and without compression of the graft. Because I want to see how much blood flow is the blood flow increased to the artery after you compressing the graft. And how much increasing, so I know how significant if he has a Steele syndrome or not. So when you send to a duplex, you have to write duplex ultrasound. Please do it with and without graft compression. Okay?
Okay. Okay.
All right. So that fistula is patent without stenosis. The vein is large and measuring 10 millimeter. The volume is 2000. There are severely damped digital waveforms that augment significantly with compression of the flow. You see, they did that. So they compress it and they found augmentation. It's very important to mention that for them to do this one, this maneuver. How do you interpret this finding? What would you do about it? What do you think is going on with this patient?
From this finding, this confirmed the patient is have a Steele syndrome.
Correct. All right. So this confirmed that he has a Steele syndrome. I accept that. When you talk about Steele syndrome, there are two types of Steele syndrome. You know what? There are two major types for Steele syndrome. One called high flow Steele syndrome and
Yes.
low flow Steele syndrome. And this is very important to know which you are dealing with because treatment completely different. So when I deal with a Steele, I want to know is this a high flow or low flow Steele syndrome. So this patient, what do you think is higher flow or low flow?
High flow.
High flow. So when you have high flow Steele, why is it important? Because when you have high flow Steele syndrome, you want to decrease the flow because the graft taking too much blood, right?
Yes.
And you need to decrease the flow. Then what you do a vein map, you do a banding because you want to decrease the flow,
Banding.
right?
Yes.
But if you have
Yes.
a low flow, okay, low flow, then the problem was the inflow. Then if you do banding, this make it worse because you already have a low flow in the fistula. It will clot it. The fistula will clot it and will not solve the issue because the issue is not the outflow, it's the inflow. Then you have to work on your inflow. Then you have to go with other procedure we can talk about later on, like Rodi procedures, drill, you know, proximal or distal approximations. You see? So this is the reason why it's very important for you to know. The reason why they give you the volume. So if patient come to me without volume, I will send him back. I need to know how much the flow volume through the graft. If they just told me, okay, it's a reverse flow, it's a good flow, it's dumping of the, you know, waveforms, there's a reverse flow, so it has a Steele syndrome, it doesn't help me because it's most important for me to know the volume flow to decide if high flow or low flow fistula to decide what treatment I'm going to deal with it. Okay?
Okay.
Please, guys, this is very important scenario. So it's important to concentrate on that. And not only this one, your real life, when you go to, not for exam, this is how we're going to deal with the Steele syndrome if you get it. So this one now we're dealing with the high flow Steele syndrome, okay? So let's see what next question. What are some techniques to treat Steele? This is in general, okay? Not this patient. I'm talking about what's technique. Remember what different technique we have for Steele syndrome. You have to remember them, guys. You have to read about them, okay?
Okay.
Do you remember them now or you need to go back, guys?
Yes. Banding, Rodi, drill, proximalization of the arterial inflow,
Okay,
and ligation thalassemia.
okay. All right, so we have all this one. Okay, So let's go to the next one now. What do you recommend for this patient now? So which one are you going to choose for this patient and why?
For this patient, high flow, I will use it the binding to decrease the flow.
Because it's a high flow. Correct. Is the way you
Yeah.
should ask. Correct. See, stop. He agree, describe the procedure, how you do the banding. Those are important.
Yeah, I will make it the incision at the near to the anastomosis, the fistula of anastomosis. Then I will use it PTFE graft around 10 centimeter length. We'll cut it longitudinal and I will put it around the
10, you said 10 centimeter or millimeter?
10 millimeter.
What, the length or the width?
The length.
What about the width?
Usually you use it the graft 6 millimeter PTFE.
Okay, so 6 by 10. Okay.
Then I put it around the vein,
Okay.
wrapping around the vein, and make it multiple suture on the graft, make it tight the vein, and check the pulse intra-op.
You check the pulse if it's still there or not.
Yeah.
Okay. All right.
If it is not, I will make it more tight, the graft over the vein
Okay.
until the
Pulse come back.
there is a different technique. Maybe due to the pulse, check the pulse of the patient return back, or I will put it pulse oximeter on the finger of the patient to check the oxygen saturation.
Okay. So you're putting the oximeter on. So what are you going to depend on, the pulse or the oximeter? I got confused now.
The pulse is better.
It's an exam. It's an exam. This is real life. You are in the war. What are you going to tell you? Doctor, the nurse can ask doctor, what do you want?
The pulse.
Oximeter, I don't want oximeters. You can have them both. I have no issue. But just tell me what do you want to do.
The pulse.
Maybe put them both. Why not? This is being safe side. If you don't answer, put them both. I have no issue with that. What's the big deal? Put them both. You know, take the pulse and check oximeter. But which one is the more important? The pulse or the oximeters?
Oximeter.
Why not the pulse? Because how many patients we see them in the clinic without steel and they have no pulses? There are lots, right? Almost every patient we do access, we don't have a pulses. So pulse is not very important. The most important to see saturations, you know. So saturation, I think, is more important. You know, I think it doesn't mean the pulse is not important, but the most important for me is to be sure that his sat went back to almost to the normal, you know. So the reason why when I finish the surgery, guys, I know if guys you do that. Always in the order you should do that also. Any patient you do an AV axis, because the problem is that all of them they have a nerve block, so they don't have a pain, or if you have a steel or something like that. So always in the recovery, I always tell the nurse to put the oximeter in the hand where the fistula to be sure have enough saturation, because you cannot rely on the pulses, you know, because most of the time you don't have pulse in the radial artery. So always in your note on the post of order is right, please check the pulse in the hand where you have a fistula. This is the way they can follow up this patient in the recovery room before sending patient home. Okay. So this is the most important. I mean, I accept the way you do it. I don't do it this way, but I will accept that, you know, because you see in this technique, there is no control. I don't have no control. You may go too tight and then the vein will thrombose, you see. This is a problem with this kind of technique. I don't like it because you have no control. You just put 6, you know, even 6 is too big, you know, because the vein, you know, usually you need it to go down to 3 millimeter really. But again, some people do this technique. I'm not against it. You can say this technique, you can use it if you know how to do it, but I will not do it. The way I really do it, I go there, I puncture the vein retrograde, I put a 3 millimeter balloon, and I put 2 tie around the balloon. So this way I know exactly how much I tight it, you know, because you don't want to go more than 3 millimeter balloons. But when you put a 6, you're not putting a 6 because you have to put a clamp and suture it, you see? So already it's going to come down to 3 or 4 at the end. Because when you put a 6, you have to put a clamp to decrease the size of the vein. And then you check the pulse or check the, you know, the oximeters. But other technique, again, you can retrograde, put 3 millimeter balloon and put 2 tie around it, you'll be fine. But again, both techniques are okay as far you know how to describe them. All right, so what do you do looking for the term of exam, BBG improvement and flow decrease to suggest you're treating the steel effectively? Then BBG improvement, flow. Very important again. Yeah, you're right. We forgot that. Also, not you are looking only for BBG improvement. You have to look for the volume because this is a high volume. So the whole aim of this treatment is to decrease the volume. So you want to decrease it to up to where? What number would be acceptable for you? You still there, Rafat?
Yes, bro.
Okay. So we are 2000. So we want to decrease volume to what?
Until the return the pulse normal,
Okay. But what's
or
an acceptable flow for the graph? I mean,
above the 600, from 600 to 1000.
to 1000, so around 1000. 600 is the lower. So you don't want to go down to the lower edge, right? You want to go to the maximum normal because you don't want to go from 2000 to 600. This is too much drop. But the maximum I accepted is 1000. So I want to go down to that 1000. You know? So I think 800 to 1000 is very acceptable. You go with the volume. So you need to have a duplex technician with you in the OR to assess the flow of through the fistula. Okay, let's change the scenario. What if the patient complaining of pain in the hand at rest without neuromotor symptoms, had upper arm brachio auxiliary AV graft with a flow volume 800 and had finger BBG waveforms that augment with flow compression? What procedure would you offer? So what we are dealing now with
Low volume.
low volume, correct?
Yes.
Low volume, what procedure? Do you do banding for this one?
No.
No banding, correct. So what kind of procedure we do?
Proximization of the arterial inflow.
Okay. He has what, axillary breaker, right?
Brachiocephalic.
No, he has, let me see, brachioauxiliary AV graft.
Yes.
So brachioauxiliary AV graft. So how you do now? Shown arterial. This is very important. You're right. You have to look for inflow. Always guys think about the inflow. You see, always we think about fistula and high flow. When you're dealing with a high flow, we just look main to the vein. When we have a low flow of steel, then we have to look for inflow. An inflow could be disease subclavian or breaker artery or auxiliary artery. If it's all normal, then we have to do one of these procedures. But before that, you need to get a CT angiogram or at least duplex ultrasound to be sure your arterial flow is fine. You're not missing any subclavian stenosis. Because if you have subclavian stenosis, you go and stent it and you solve his issue. You see? So before you jump to any procedure, just be sure you order as a CT angiogram or duplex ultrasound to be sure no proximal stenosis. Okay?
Okay.
All right. So what kind of procedure are you going to do for him? You said proximal arterialization. How you do that?
I will make it the separate incision. One the axilla to dissect it, control the axillary artery, and make it a heparization. The patient tunneling from the distal brachial side to the to the axillary artery by Prpf graft.
Correct. What size?
Usually we use it 6 millimeter.
6 millimeter. Correct. So you 6 millimeter Prpf graft. So like really you convert it from brachioauxiliary to auxiliary AV graft, correct?
Yeah.
And what you do with the anastomosis graft with the breaker artery? You get a new graft, right? I mean, you get a new piece of the graft. You suture the breaker artery. Where the other end you suture to what? Where you suture the other end of the graft? You follow me?
Yes.
Okay. So you can do proximal anastomosis, right? So the anastomosis is a graft with a breaker artery, right?
Yeah.
So you have to take it down and now put the anastomosis all the way to auxiliary artery, correct? So what you did is correct. You brought a new graft, you suture the breaker artery, Then you cut the graft above the brachioaxillary, the brachial artery, above the brachial artery, and suture graft to graft. So this way you convert it from brachioaxillary AV graft to axillary AV graft. And you suture the stump of the graft next to the brachial artery. You follow me, or should I say
Yes.
it again? Okay.
Yes. Okay.
So you do axillary incision, you bring a graft, short graft, maybe 10 centimeters. You suture the brachial to the axillary artery. Then you go down to the brachioaxillary anastomosis. You cut it above the brachial artery. You do end-to-end anastomosis between the old and new graft. And the stump you suture it with the Proline 5 organic suture. Okay?
Okay.
So this way you convert it from brachioaxillary to axillary AV graft. All right, so you did that. There's a bubble.
It's not clear, Dr. Samer, معلش.
Not clear? Okay.
Yeah. We have brachioaxillary من البداية. From
Right,
the start.
right,
And now we will make it axillary.
correct.
طيب
So
احنا will connect the new graft to the axillary artery and loop it.
not
Connect
loop
it
it,
to
no,
the
just
old
straight.
graft.
You don't have to loop it, just straight.
طيب
Because
when?
in the medial aspect, right? The brachial, where is the brachial anastomosis? The medial aspect of the arm, correct?
Yes, yes.
And the axilla in the medial aspect. So both in the medial aspect.
Okay.
So you clamp the graft above the anastomosis, the brachial artery, you cut it,
Mm-hmm.
you suture the stump, you forget about it, okay?
Yeah.
And the other end
بعدين
of the new graft, you suture to the old graft.
Okay. So the drainage will be through axillary artery to the old graft going to the axillary vein.
Correct. So you convert
Okay.
it from brachioaxillary to axillary AV graft.
Clear now, yes. Okay.
Okay? So you just put small piece in the medial aspect. You don't have to tunnel. I mean, you tunnel it, but under the medial aspect of the arm. And the good thing about this way, they can use the graft right away because
The old one is there.
yeah, old one is still there. And what you do in the medial aspect, which is they don't use it anyway, you know.
Yes,
So
clear.
you just you just move the anastomosis from brachial artery up to the axillary artery. This is the whole idea.
Okay.
All right.
Great.
Good. You ask question, guys, anytime. I have no problem. You can stop me anytime. Okay, so let's say there's a bubble thrill and return of the radial pulse. What's the theory behind proximalization of arterial flow work to reduce Steele syndrome? Yeah, I don't see important questions. Why do you think this, if you do proximal, will get you resolve his Steele syndrome? Because the artery is larger, guys, correct? And the
flow is high.
second thing is that, yeah, the more you go proximal, always the less, because there's a lot of branches. So you can get blood, he can get collaterals from different areas, you know. The more you are close to the distal end, then less collaterals, then you get more Steele. Like the same, like hepatic artery, okay? If you ligate the celiac artery, nothing happened. But go and ligate hepatic artery, then get hepatic liver ischemia, correct? So anytime you ligate the artery close to the end organ, you get more ischemia because it's no collateral, less collaterals. The more you cut, you ligate it proximal, is less damage because it's a collateral, they come from somewhere else. And the same idea here, because the more you go distal, the hand will get less collateral, so you get more Steele. The more you bring your anastomosis proximal, so even the graft take more blood, the same amount of blood from the hand, from the artery, but the hand get more collateral from surrounding, you know, the branches from, you know, around the shoulder, you get more blood, so you get more blood down to the hand. So this is the whole idea from that. Okay. All right, let's change the scenario again. What if the patient complaining of pain in the hand at rest with neuromotor symptoms and no tissue loss, and had upper arm brachiocephalic fistula with flow of 800 and had finger BBG away from that augment with outflow compression? What procedure would you offer? Okay, so he has a fistula now, not a graft. And he has a Steele syndrome and he has neuromotor symptoms, but no tissue loss. So what procedure would you recommend it?
I will check the artery, the inflow, and echo for the patient to cardiac function to check the also the pumping.
Okay. You did that. But I'm asking what procedure would you do, not what you do next, what procedure? I think they're talking about surgical procedures, right? Let me see. Oh, so they did an echo. So what do you do next? Again, they want to know what procedure you're going to do. So what other
Maybe
procedure we have? We said for
Rudy,
perfusion, we still have two of them. We have a drill,
Rudy.
have all of them, proximal anastomosis or Rodi, correct?
Yeah.
Okay. Usually when you do proximal anastomosis, say the case it's more to the graft because you can put a graft. So it's easier to do it with the graft. With the vein, it's more difficult. You can still do it, but then you have to put the graft with the vein, which is not the best, but you can still do it. I think the best way in here, when you have a fistula, brachycephalic fistula, when you have a steel with low flow, then to go to the Rodi procedures, which you put a small vein between the ulnar artery or radial artery and the fistula. Okay.
Uh,
Hand
sorry, Mr.
revascularization.
Samer.
Doctor?
To the fistula or to the brachial artery?
No. The fistula, the whole thing's now, you see what the idea of Rodi is
Yeah.
that you're doing on the brachial artery, right? Before the bifurcation, right? The fistula
Okay.
taking blood from both, from ulnar and radial, correct?
Mm-hmm.
But when you do, so you want, the most important is the ulnar or radial to the hand?
Ulnar. Usually ulnar is
Ulnar.
dominant.
So I had to keep the ulnar. So what happened? I put a vein bypass from the radial, distal radial, to the fistula. So the blood will take it, so the fistula will take blood from the radial, not take it from the brachial. So the blood will go through the ulnar first, and then the seed from the radial, which is not very important because the radial is open first.
So we ligate the brachial artery?
Yes. No. With the Rodi procedure, Sam, you want to move your bypass from the brachial artery to the ulnar or radial. Which one is more dominant? You have to decide, you know?
Okay.
All right. This is called.
So, yeah, so it's
and most
revision.
of go to the radial because the ulnar is dominant, you know? But say the radial is dominant, then you go to the ulnar. You go to less dominant because you want to save the hand now and you want to keep the fistula open. So you just do a short bypass. So you ligate the anastomosis and you do a jump vein graft between the radial artery and the old vein.
Okay. Okay.
So now the fistula taking blood from the radial artery.
Okay, so we ligate the vein
Yes.
proximal to the anastomosis, old anastomosis,
And you cut it?
we anastomose between the old vein to the radial artery or ulnar artery.
Yeah, which is not dominant, right? To keep the dominant for the flow, because now
Okay.
your hand is your concern.
Okay.
So I use non-dominant artery, you know. The reason
Yes.
why when we do a radiocephalic fistula, rarely we see a steel because ulnar is open, you see?
Yeah.
Even though now we are distal, you see, when you talk about this, yes, we are distal, but because you have two arteries. If you only have one artery, the hand, then radiocephalic be the worst fistula to cause a steel.
Yeah.
But really, it's the least give you a steel because you have two arteries to the hand, you know?
Yeah.
So this is what you do it, okay?
Okay, clear.
All right. The patient want to keep the fistula, try distal hand revascularization procedure. What option for revascularization? We talk about it. What difference between two procedures? I think I know what they mean by two procedures. I think he talking between drill and Rodi, you know? Drill procedure is different. Drill procedure, does anyone know how drill procedure work?
Usually
Yes.
we do bypass from the a vein bypass from the proximal brachial to the ulnar artery. with ligation the distal of the brachial fistula.
With ligation of what?
The distal of the brachial artery of current fistula.
Then the fistula will clot if you ligate the blood distal to the anastomosis.
Distal
Correct?
to anastomosis, yeah.
Correct. Yes, this is anastomosis. So the same. So this way, the hand will take the blood first before go to the fistula. So in drill procedure, you do bypass from the proximal brachial artery, either to distal, depending how space you have, either to distal or to the ulnar artery, the dominant one, or the distal brachial artery, depending how space you have between the anastomosis and brachial artery bifurcations, you know. And then you ligate the brachial artery distal to anastomosis because you want to reverse retrograde flow to the fistula, okay? So in this way, blood will go through the vein, bypass to the hand first, and then go to the fistula. So this way you keep the fistula working and you have flow to the hand. But most important part of this procedure, the anastomosis on the brachial artery has to be how far from the anastomosis of how far from the fistula?
2
least,
centi?
how much?
2 centi?
No. Then 2 centimeters still get a steal because it's too close. You have to be far. Because if you put it very close, you don't get any benefit. You're still going to steal from the hand because this is a low flow system. So the blood always has tendency to go to low flow system. So even if you do anastomosis proximal, the blood will prefer to go through the fistula than the hand. It has to be at least 10 centimeters. Okay, at least away from anastomosis. So your proximal anastomosis should be at least 10 centimeters away from the brachiocephalic AV fistula. Okay. And we do this one if you have a tissue loss, if you have a necrotic, because you need enough blood flow to the hand. So the only time we do a drill if you have a tissue loss. If you only have a pain, we prefer to do a RODI or proximal arterializations. But if you have a tissue loss, then we prefer to do a drill. I don't like a drill. I did it a couple of times, but I don't like it because you ligate the brachial artery. If something happened to the bypass vein graft thrombose, then you have acute limb ischemia. This is dangerous. So the reason why I don't like really RODI much, you know, drill procedure much, because now the hand depend on the bypass, and we know always the bypass, they get problem down the road. So I don't like to do that, but it's there in the book, and this is the indication if you have a tissue loss. All right, we are getting very close to the journal club, so we have to finish. What you recommended and why? Would you offer different procedure to same patient who has a tissue loss? Yes, we do a drill. If there's no tissue loss, we do a RODI procedure. On angiogram with open outflow, there is a minimum flow into the forearm, and with compression flow, the hand is normal. Explain how to perform dream procedure. We talk about it. What would you do if you have the same patient with tissue loss, ejection fraction 35%? Patient has ejection fraction 35% and a tissue loss.
Ligation of the fistula.
Just like in the fistula, yeah. No, nothing will work with this patient. Has no heart. There's nothing, no ejection fraction. So his main issue is the ejection fraction. This one really. So all this bypass will not work. So the best way is just to ligate the fistula. All right, guys, you did great. You passed. We still have one case, but I don't think we have a time. We have to prepare for the journal club. Any question? Anything? Any concern?
I have a question.
Yes, please.
In patient with autogenous fistula like brachiocephalic, we can do proximalization of arterial inflow using great saphenous vein?
You can do it. No problems, yes. But if you're going to do a vein, why just do the drill? It's easier and shorter vein. Yes, but you can do it, yes. I have no problem with that. But if you think about it, it would be easier just do a short vein and move it down to the radial than to go all the way up to the axillary, you know? But yes, you can do it, yes.
Okay, thank you.
Okay. All right, guys. Thank you very much and good luck. If you want us to meet tomorrow, if you have a question, something like that, let me know. We'll keep in touch through the WhatsApp.
ماشي الله يعطيك العافية.
تسلم.
Good luck, guys.
شكرا دكتور.